Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by our deputy editor, Nick Bostock.
Hello.
And senior reporter, Kimberley Hackett.
Hi, everyone.
To talk about some of the key news stories affecting general practice. Coming up, we're talking about GP recruitment under the Additional Roles Reimbursement Scheme and what new figures tell us about how that initiative is working. We're also talking about cuts to integrated care boards, what they could mean for general practice, and how the financial constraints within the NHS are already impacting on funding for local services provided by GPs. Our good news story this week is about funding for research in GP practices.
Hi, I'm Pat Anderson, editor of MIMS Learning, and I'd like to invite you to join 2 free webinars on the topic of cancer diagnosis. First, on 23rd of April at 7 p.m, GP Dr. Sunita Kochhar will talk about diagnosis of skin cancer. And on 7th of May at 7 p.m, GP Dr. Pipin Singh will hold a case-based discussion with oncologist Dr. Pauline Leonard about how to achieve better outcomes for patients with cancer. Sign up now at mimslearning.co.uk.
So Nick, let's talk about the Additional Roles Reimbursement Scheme and recruitment of GPs. So GPs were added to the ARRS halfway through the last financial year, so 2024-25, just after Labour won the election in a bid to tackle concerns about GP unemployment among newly qualified GPs specifically. We've seen figures published in the last week or so setting out how that worked. Firstly, what was the government hoping to achieve with this plan? And secondly, did it actually work?
The government announced about a month after last year's general election that it would put an extra £82 million into the ARRS to create more than 1,000 GP jobs. So that was the basic target. And the funding was available, as you mentioned, for the second half of the 2024-25 financial year. So from October 2024 to the end of March this year. In terms of what the government wanted to achieve, obviously it wanted to hit that target, but also to improve access to GP appointments and to begin to tackle what Wes Streeting was calling at the time the absurd situation in which many GPs have been struggling to find work despite the fact that general practice is under massive pressure. So did it work? Well, on the basic recruitment target, it does look like the scheme has worked. The government promised 1,000 GP jobs. And we found out this month that 1,503 GPs had been recruited to ARRS roles by the end of March. Full-time equivalent figures are only available up until the end of February, and those show 851 full-time equivalent GPs in ARRS roles. So once you add in a further month of data, that figure might well be at or above the 1,000 mark as well. We know there's been a lot of cajoling from NHS England to get the numbers up over the past few months because uptake was slow. So many of these GPs haven't been in post all that long. There were fewer than 600 full-time equivalent GPs in post by the end of December, for example. So that's halfway through the 6-month period that the ARRS GP job scheme ran for in the last financial year. I mean, ultimately, though, it's been successful in terms of achieving that basic target of creating 1,000 plus GP jobs by the end of the last financial year. And both the RCGP and the BMA have said it's encouraging or a step in the right direction. But in terms of the wider context, the BMA and RCGP both point out that this is far from solving the unemployment crisis in general practice overall. We've talked a lot about the fact that thousands of GPs have been struggling to find work because practices can't afford to recruit. And with this scheme, only GPs who qualified within the past 2 years and haven't previously held a substantive post in general practice can apply for these ARRS jobs. So for more experienced GPs who are struggling to find work, these jobs haven't made any difference at all. And the BMA and RCGP say that solving that needs basically a step change in core funding for general practice. And that might be some way off even after the big contract deal that we've seen this year.
Looking at those figures in a little bit more detail, I mean, you know the GP workforce figures inside out and back to front. Are these definitely new GPs that have been added to the workforce? Are these GPs that are already showing up in those workforce figures that we talk about on the podcast all the time?
The background information from NHS England on these figures does suggest there's potentially some overlap. So some of these ARRS GPs could well be showing up in the national GP workforce figures as well. Just to be clear, the total number of full-time equivalent GPs in England in the most recent official workforce data is 28,248. So if the ARRS brought in something like an extra 1,000 full-time equivalent GPs, that would be a pretty massive boost in just 6 months. But the reason why there may be a bit of double counting going on is just to do with the way PCNs and practices might be recording salaried GPs. So NHS Digital's website says there's guidance intended to avoid this happening, but it's potentially still the case that some GPs claimed for through ARRS have been recorded as working for practices and are therefore included in the GP workforce statistics nationally, as well as in the ARRS or PCN numbers. There are also some questions about whether, as the ARRS numbers have gone up, there may have been a dip in locum numbers employed at practices. So one GP I've spoken to said he's been told personally that a practice he works at as a locum decided to reduce his sessions, effectively replace part of the work he provides as a locum with an ARRS GP role. So that's a worrying story in terms of the wider unemployment situation, but it also reflects how cash-strapped many practices are.
The data in those figures also provides a breakdown by integrated care board and right down to primary care network level. What does that data tell us about GPs employed under the ARRS?
I've written a couple of things over the past week or so on this, and there's really significant variation across the country in terms of ARRS GP jobs. What we found from looking at the figures is that 2 in 5 PCNs across England, so it's just over 500 in total, hadn't claimed for a single ARRS GP job by the end of March. So there are a small number of claims still being processed, but that shows that in many PCN areas, either they didn't want to recruit an ARRS GP or GPs, or they weren't able to recruit with the money available or the job that was on offer. We also know from the difference between the end of March headcount figures and the end of February full-time equivalent numbers that there were about another 100 PCNs that only brought somebody in the final month of the last financial year. But quite a few PCNs seem to have been a lot more enthusiastic than that, or successful perhaps in recruiting. About a third had hired 2 or more ARRS GPs by the end of March. 1 in 6 had 3 or more, and a couple of PCNs, bigger ones generally, have brought in more than 10 GPs to ARRS jobs. So there's really big variation nationally. It could reflect in part things like how much support or pressure ICBs put on practices in their area to use the scheme. You know, we talked earlier about the fact that there was some cajoling from NHS England. So how successful was that at a local level, for example? But in some ICBs, nearly all PCNs recruited an ARRS GP, and in others, up to 70% of PCNs in that ICB area haven't used the scheme at all.
You have done a couple of really good analysis pieces on that people can find on the website. There's one with a map showing the sort of ICB breakdown, and there's another one which has got a table of all the primary care networks in England and how many GPs they've recruited under the scheme. So do have a look at that. We'll put links to those in the show notes. Nick, what's been the reaction to all of this? The government has presented this as a huge success, hasn't it? What have GPs had to say?
The government has presented this as a big success, which is perhaps not unreasonable. I mean, it promised to create more than 1,000 GP jobs, and 1,500 GPs have been hired through ARRS to GP jobs. We published an opinion piece from the Primary Care Minister, Stephen Kinnock, just at the time the figures on ARRS GP jobs were announced. And he said that adding GPs to the ARRS had been a crucial reform, and that this was all part of the government's plan to support general practice, to fix the front door of the NHS, was his term. And I think overall GPs can absolutely see the positives. It is good that the government has recognised the unemployment crisis in general practice. It's good that these jobs have been created for newly qualified GPs, and that the government has found extra money to do that with. But as I touched on earlier, GPs are also making the point that this doesn't mean the unemployment crisis in general practice has gone away. These jobs aren't available to most GPs, and there are still large numbers of GPs struggling to find work. Both the BMA and the RCGP have said that to really tackle unemployment, we'd need to see a substantial increase in core practice funding to give practice the financial headroom to hire more doctors. And part of the reaction from GPs has also just highlighted some of the reasons why take-up of ARRS GP jobs was relatively slow, certainly at first. GPs I've spoken to say there was some reluctance both on the part of potential employers and potential recruits, and that's because the funding on offer was widely seen as far below the going rate for a fully qualified GP. So practices within PCNs have often had to top up funding to make these posts attractive enough. And if that's the case, in some areas, practices simply won't have been able to afford that. There have been concerns too about the fact that often ARRS jobs are divided across multiple locations within a PCN. So potentially they don't provide the support that a practice-specific role might for a GP, and maybe they aren't the best for continuity of care, for example. So I guess what this comes back to is that this is a good first step, but now general practice, and particularly GPs struggling to find work or practices struggling to afford to recruit, need more support to build on this.
We know that the way primary care networks can use the ARRS to recruit GPs has changed this year. I mean, we've talked about that on the podcast in the last few weeks. So last year, PCNs had a limited pot of money for GP recruitment, but this year they can use any amount of their ARRS funding to recruit GPs, although those doctors will still have to be within the first 2 years of qualifying. Do you think those changes mean we're likely to see a big uptick in these figures that we've been talking about? Do we know when the next set of data about this is likely to be published?
Some GPs I've spoken to about this were pretty sceptical about whether ARRS GP numbers will rise a lot over the coming year, despite the extra flexibility PCNs now have with the ARRS funding. And there are a couple of reasons for that. So total ARRS funding in 2025-26 is worth nearly £1.7 billion. That's up from about 1.4 something billion in 2024-25. But that doesn't mean there's suddenly loads more money available for hiring GPs. So much of the uplift will be swallowed by pay increases, additional employer national insurance costs, and so on. And even though technically PCNs can use all of the ARRS cash to hire GPs if they want to now, they're actually already using most of the money to pay for other staff. So it's just not available. Some of the uplift is also just a rollover of funding for GP jobs that have already been created. So the actual increase in funding, after all that's factored in, is quite limited. And obviously, not all available GPs can actually be recruited through the scheme because ARRS jobs are only for GPs in their first 2 years post-CCT. So we'll be watching for updates with interest over the coming months. NHS England has said it will update the figures on ARRS GP jobs, so we will get more information. The first set were published alongside PCN workforce stats, which come out monthly, so it's possible that we could start getting monthly updates on ARRS GPs, but I don't think that's been confirmed specifically, so we're going to have to wait and see on that front.
So moving on, let's talk about the cuts integrated care boards or ICBs are facing, and also about funding for local enhanced services. So let's start with the ICB cuts. We've talked a bit about these cuts on the podcast before when we discussed the government scrapping NHS England, but since then, more detail has emerged. At the start of this month, the new NHS England Chief Executive, Sir Jim Mackey, wrote to ICBs explaining what they would need to do in the coming months. ICBs have basically given until the end of May to set out how they plan to reduce their running costs by a massive 50%. Boards are set to receive details of their funding allocations by the end of April and use that to inform their plans, which will then need to be signed off by NHS England leaders at the end of May. Despite these cuts, Sir Jim said in that letter that ICBs would still have a critical role to play in the NHS as strategic commissioners, and that they would be central to realising the ambitions that will be set out in the forthcoming 10-year plan. Strategic commissioning means that big overview of the local system, managing contracts, looking at data on outcomes, that sort of thing, perhaps rather than being very hands-on around delivery. The letter suggested that ICBs should focus cuts on any areas where there is duplication allocation, and some examples were given, such as assurance and regulatory functions, including safeguarding, where some of this work is already done by providers. Also, wider performance management and communications and engagement, where similar functions also exist in local authorities and NHS providers. But despite all these massive changes, ICBs are still going to be expected to deliver on some key issues, including the development of neighbourhoods, which we're going to discuss in a minute, although the letter did acknowledge that that was going to be really challenging to do. Kimberley, let's bring you in here. You've been talking to GPs about some of their concerns about what these cuts could mean for general practice. What are they most concerned about?
Now, we know that staff will lose their jobs because of the ICB cuts, and the GPs I spoke to said that this was one of their biggest concerns. About 18 months to 2 years ago, many ICBs went through a round of redundancies, and Dr. Zoe Norris, who is the Chief Executive Medical Director of Humberside LMCs, said that the fallout from these job losses have already given an insight as to what could happen with the upcoming cuts. She said that there has been an organisational memory loss because of the previous ICB cuts, and that some of those staff members who had worked directly with primary care had previously worked in CCGs, and that's the NHS organisations that were phased out and replaced by ICBs in 2022. So, these members of staff had the historical knowledge and relationship with GP practices. Now, Dr. Norris wasn't criticising the ICB. She recognises that they are struggling too, but she said that without the staff there who know the primary care world, there has been an impact on GP practices because they are struggling to get information from the ICB as quickly as they used to. She said that even the LMC has seen more queries come their way because the ICB doesn't have the answers that it once used to. She says that in her area there is an anxiety about the upcoming cuts because the GPs in the area have previously seen the fallout from the last round of cuts. And for Dr. Lisa Harrod-Rothwell, the CEO designate of London-wide LMCs, she warned that the loss of organisational and local knowledge could cause a distraction for clinical priorities. She said that the cuts could cause a risk to the work that GP practices, LMCs and commissioners have already been doing to improve interface work between primary and secondary care. She added that the best way for successful change is to give the people delivering care autonomy to develop solutions that meet the needs of their population.
Just to sort of back some of that up, I've spoken to a couple of people from LMCs in the past week or so. They've both said that they're really worried about the impact of these changes. What one person said, if we're losing 50% of staff in the ICB, we're going to be losing good managers, and they're people that general practice has relationships with, that general practice leaders locally rely on for support. The point that Kimberley made about the knock-on impact on LMCs in terms of having to step in and fill the void in terms of supporting practice for some of the things that ICBs have previously done is also important. I mean, one GP also mentioned the fact that some of the people losing their jobs within ICBs could well be GPs themselves in clinical director type roles, clinical advisory roles within the ICB. So that potentially speaks to not only a loss of support for general practice, but also a reduction of the voice that general practice has within ICBs potentially.
That's a concern that people I've been speaking to have said. I mean, much the same as what you two have both said, is that they are really worried about this loss of expertise at the ICB. But also, like you said, Nick, some of the people who are going to be at risk of redundancy are likely to be GPs or people with a clinical background who have been quite invaluable for helping do things on a local patch that might improve care for a specific condition, or be leading on projects that practices are probably very involved in. And people I've been speaking to are quite worried about how that's all going to shake out in the wash, as it were. Health and Social Care Secretary Wes Streeting appeared in front of the Health and Social Care Committee in Parliament last week alongside Sir Jim Mackey, and he was asked about all of his plans for reforming the NHS, including these cuts to ICBs. And in that evidence session, he said that the Department of Health and Social Care has already had requests from integrated care boards themselves about possible mergers. and that the department's very open to those kind of discussions, apparently. He said he wanted to see pressure from below up for this kind of change. So he wants to see ICBs really wanting to change things and come up with new ways of working rather than it all being a top-down diktat. That was the sort of impression I got from what he was saying there. But I don't think that most ICBs will really be feeling that they have much of a say in all of this. If they are looking at mergers, it's probably because they're backed into a corner and being forced to consider this as an option. Wes Streeting also really reiterated in that session that he really wants ICBs to go after duplication, as he put it, when they're looking at how they make these cuts. So that might sort of give a bit of an indication of the kind of areas they're looking to lose staff in, I suppose. And I guess one of the other big concerns from a policy point of view about these cuts is around a move to neighbourhood NHS, as I mentioned earlier. This idea that we're going to move more care out of hospitals into the community. I mean, is the NHS going to be able to do that with significantly less managers at a local level? We've been through two pretty bruising reorganisations, in the space of a couple of years by the time they come out of this one. Kimberley, you wrote a story about exactly this last week, didn't you?
Yeah, I had a chat with Ruth Rankin, who is the NHS Confederation's Director of Primary Care, and she told me that if the cuts to ICBs come in the form of redundancy, there is a chance that the transition to NHS neighbourhood models could slow down because ICB staff are understandably worried about job losses and the impact of seeing others leave, which could in turn slow down the commissioning of services for neighbourhoods. She also said that in the past, when there has been large-scale changes to the NHS, there has been enough money to run the current service and make the changes, but we don't have that luxury now. She also said that without adequate funding, it will be a challenge to transform care in line with whatever comes out of the 10-year plan and seeing more care moved into the community, while at the same time delivering some of the immediate changes such as improving access to GP appointments and reducing hospital waiting times.
So much of all of this really is very reliant potentially on the government's 10-year plan, which is due to be published in June, as far as we know. I suspect sort of around after potentially the spending review, which is due to finish in the early part of June. It's pretty clear that neighbourhoods and this shift from hospital to community will be a big part of that plan, as well as those other two shifts that we know so much about, from analogue to digital, treatment to prevention. And you would have thought that ICBs would have had a key role to play in all of that before the announcement about these cuts. But really, it feels like ICBs will be very much stripped back to just focusing on commissioning, as I mentioned earlier. And it's quite difficult to see how they're going to be able to drive forward neighbourhood working, which is going to be a really big ask of the NHS, I think, because we're talking about working across traditional boundaries between primary, secondary care, mental health, community services, social services. That's not easy stuff to do. It's a big change. And I think the general feeling from people I've been talking to is that the 10-year plan is probably not going to be really prescriptive about what neighbourhoods look like or how they're set up to give local areas the freedom to design services that meet local needs. But that again potentially makes all of this much more difficult to do if there's no clear roadmap about how to actually do it. There isn't really any consensus about what a neighbourhood is, how big it should be, what it should focus on at the minute. That letter I mentioned earlier from Jim Backey said that ICBs would need to make these cuts at the same time as, and I quote, recognising the need to commission and develop neighbourhood health with the delivery being a provider function over time. I mean, it's really not clear exactly what that means. And someone I was talking to who works in an ICB said that they weren't very clear on what that means either. But it does suggest that if neighbourhood health is to become a provider function in time, it is probably something that providers will potentially be contracted to do or incentivised to do or judged on outcomes that link into this way of working. And you can certainly see that could be the direction of travel that grows out of the 10-year plan in the coming couple of years. Maybe also something that we will see feature in discussions for a completely new GP contract over the next couple of years, which we talked about last time on the podcast. One other side to all of this is funding, and obviously these cuts are being made to save money, and the government would say to free up resources for frontline care. But this is all happening within a health service that has very constrained finances at the moment, and lots of ICBs are overspent. So there is also the potential this could impact on funding for services that are commissioned from GP practices locally. Kimberley, we spoke on the last news podcast about the success that a local medical committee in Humber and North Yorkshire had in achieving a big increase in funding for local enhanced services, in part because of collective action. But last week you wrote about practices in another part of England that are having some real challenges with local enhanced service funding, didn't you? What's going on there?
So in January, Lancashire and South Cumbria ICB proposed a LES funding package worth up to £31.50 per patient, which is equivalent to around £58 million across the area's 196 GP practices. But then the ICB had to reduce this offer in February to £26.50 per patient due to the ICB's reported deficit of £350 million. But it has since been reduced again to just £22.44 per patient on average across the area. Now, unsurprisingly, the GPs in that area aren't happy with this new offer, and the Lancashire and Cumbria Consortium of LMC said practices were considering handing back or refusing to sign up to any of the 12 LESs covered by the funding offer if the ICB does not at least honour the £26.50 per patient proposal. Dr. Adam Jandua, who is the LMC's chief executive, told me that the changing funding offers has understandably angered GPs, and it has made it really hard for practices to balance the books because they don't know the level of income they will receive for the 12 LESs that includes ECGs, phlebotomy and wound care. He said that he thinks it's entirely unfair that GP practices are bearing the brunt of the ICB deficit when it is likely that it could stem from secondary care, given that, GP practices can't go into deficit. Now, he said he's happy to negotiate with the ICB, but doesn't want to hear about the financial struggles of the ICB, considering it's just not the fault of general practice. I also spoke to Dr. Mark Jorborn, an East Lancashire GP who is in one of the worst funded areas in the ICB. He really wasn't very happy that the ICB has reneged on its initial proposal to level up the practices in the area. He actually said that a funding overhaul should go beyond equalising payments across the patch, and the ICB should direct extra funding to deprived areas with the greatest health challenges. Since we ran the story, the ICB and LMC have been back in negotiations, and we will keep everyone updated once they come to a close.
Nick, do you think we'd like to see more problems like this in the future? The BMA has been really keen to stress that collective action locally should still be going ahead, and it has been highlighting a lot of the successes that's been achieved as a result of this, like that Humber and North Yorkshire win we talked about last time on the podcast. But it's not all like to be plain sailing, is it? I mean, this example that Kimberley's been talking about shows that. We know that local enhanced services now make up a really significant part of practice income. What have GPs been telling you about this?
One thing I was just thinking about while I was listening to Kimberley talk through the experience in Lancashire and Cumbria, with some of the comments that one of you made earlier around ICBs potentially merging as time goes on. You talk about the loss of focus on the basics of supporting general practice in any of those areas. But also, one of the things that happens in those situations, it's already the case that part of the problems that LMCs and GP practices locally have with their local enhanced services and the variation in those services between practices and between areas is that they've inherited themselves variable situations from predecessor organisations, right? So ICBs at the moment have inherited different situations from the CCGs that used to commission local enhanced services before them. And the CCGs themselves inherited variations in the situations they inherited from primary care trusts that came before them. And so if you have another round of mergers, ICBs come together. Two ICBs might have had different approaches to how they commission different elements of local enhanced services. And that means, again, at the very least, a sort of upheaval, changes in funding for practices and a lack of continuity and consistency in what practices can expect from the commissioners that they're dealing with. Just to come back on the question you actually asked, enhanced services, obviously, these are the things that are outside the core work practices do in return for their basic funding per patient. And they actually make up a pretty substantial part of overall income for practice. Some of those enhanced services are commissioned nationally. Those are directed enhanced services, and all practices have access to that work. But local enhanced services are non-core services commissioned locally. Because of that, there's a lot of variation across the country and between practices in terms of the funding they receive, the services they provide in that element of non-core work. They often make up, more of practice total income than the QOF, the Quality and Outcomes Framework, which is the list of clinical performance targets that practices are measured against. A King's Fund report, I think, this year said that QOF made up about 10% of practice income, and accountants say that local enhanced services can be well in excess of that. So deals on these local services are really important for practice income. And as Kimberley's reported, how those deals are going is really variable across the country. And if funding, though, for locally negotiated services doesn't increase, that just eats into the value of the national contract uplift and effectively undermines it. So part of the reason for practices taking collective action in the first place was to pressure ICBs into offering proper funding uplifts for these non-core services, which generally haven't seen funding rise in line with uplifts to the national contract in recent years. If the drive to cut ICB costs means that deals on local enhanced services don't go well in some areas, the BMA has been really clear that practices will continue to take collective action on a local basis to push back.
Before we go, we've just got time for our regular good news story, which this week is about research in general practice. Kimberley, this is something you wrote about.
Yes, so the National Institute for Health and Care Research, that's an organisation that funds and delivers health and social care research, has set aside a total of £20.25 million for primary care organisations, including general practices. Under one investment stream, £10 million has been ring-fenced for primary care organisations so they can use the money to pay for new research equipment, refurbishment of buildings to carry out research, or construct temporary buildings. GP practices can apply for up to £300,000 and the money will be awarded over a period of up to 29 months, starting on the 1st of November 2025. In another scheme, £10.25 million has been set aside for GP practices and other primary care organisations. The funding can be used for ensuring that the trials include people from different backgrounds and provide training to enhance the skills of the workforce providing the research. Now, these two funding streams have been allocated for primary care in response to the government's call to move treatment, care and research from hospital to the community.
Well, that's it for this week. Thanks for listening, and thanks so much to Nick and Kimberley. I'll be back next week when I'm speaking to Chair of the GP Committee for England, Dr. Katie Bramall-Stainer, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.